So, good evening all. Thanks for your patience. We got a little bit late this evening, but now we are ready to start. So I would introduce the speaker to all of you. So we have a very senior alumni as a speaker today, who will be talking about a very important but often neglected issue of palliative care in medicine. So Sukdev, the 1975 batch alumnus of our Ramakrishna Mission Vidyapit Devgar, he has done his MBBS and MD from Utkal University in 1982 and 1986 respectively. And then he did his MSc Palliative Medicine from Cardiff University in 2011. He has got training from AIMS New Delhi, Tata Memorial Hospital Mumbai, International School of Cancer Care Oxford, and the American Cancer Society Washington. He has presented his papers at several international conferences in India and overseas and has more than 500 citations in indexed medical publications. His interests include tobacco cessation, preventive and palliative oncology, etc. He was also the president of the Indian Palliative Care Association and a member governing body of the Indian Anesthesia Association. So now I would request Sukdev to take over the proceedings and start the.
Okay. Yes, thank you so much. It's a brilliant opportunity to share some of the important things. And I'm so sorry that I have delayed the traffic. And I can see my batchmates Vinay and Vishwajit there. So let's see. This is something little different and not much taught in the medical curriculum. Gradually, they are starting to introduce palliative medicine into the MBBS as well as all the MD courses. But things are still a lot of things, lot of far away because a lot of persons suffer when the disease advances. So before that, a little introduction about cancers and cancer. Cancer is not a single disease. It's a variety of disease when normally our cells grow and stay for some time and they die. Most of all our cells they die. Like the RBC stays for 3 months and then they die. All these cells are destined to die. But sometimes there is a genetic message to all the cells to die at the overage. When the God or nature, whosoever, they know that after some certain point of time there is some detriment mention of the activities. The cell has to die. But at some point of it, there is some genetic change given to the cells to die, but that system doesn't work. Some aberrations occur and the cells, they don't die. They continue both in size and number. So that's why that gives a tumor and the growth is there, the cancer cells. Lot of activities going on in the labs, how to do that, how to control that. So lot of things are happening, lot of molecules, new molecules are coming. The cure over cancer is still a distant dream. So when there is a cancer cell, normally the cancer occurs, there is a diagnosis, then the treatment is mainly 3 types: surgery, radiotherapy, and chemotherapy. So when the surgeon operates, he tries to remove the tumor, and with the tumor, he also removes some healthy tissues. Similarly, radiation also, there are 2 types of radiation. One is teletherapy, that is from the distance. One is brachytherapy, which is from within the tumor cells. So they also try to burn the cells because of the high voltage radiation. They kill they change the intracellular mechanisms and the cells die. So sometimes even after the surgery, the surgeon has removed the main tumor, the nodes, but some residual things stays back, and the cancer, because the cancer, they are immortal, they try to grow. They try to grow, and there is a need for repeat surgeries. Similarly, the radiation therapy also, they give a second dose of radiation is also given to the cancers which comes back. Then chemotherapy also, at certain point of time, the chemotherapy really works. But after some time, there is a drug resistance. So then they go for a second line of treatment. So what is the prognosis of cancer? That is it's called rule of 3. That means 1/3 of the cancers are preventable. That means if you can take proper precautions, if you avoid those carcinogens, certain chemicals like tobacco is one of the good carcinogen. And so if you can avoid this, you can prevent completely that cancer will not start in the first place. So there is cancer, one third is preventable. Second is treatable. Even if the cancer has occurred and it has become perceptible, the person has gone to the doctor and the doctor has diagnosed. So that can be treated and can be removed. So this is the second part of the rule of three, the cancers. The third is that is incurable. That whatever you do, like liver cancer, so many cancers are incurable, like malignant melanoma can't cure. So you have to contend with the initial treatment, then we have to follow the patients to the death, and we support that. So I compare with the three livings that we have got: that sattvic living, rajasic living, and tamasic living. Sattvic is just like one third, that is preventable. Nothing will happen. If you have a real sattvic life, Vedic life, then probably cancer will never touch you. But rajasic means there little comfort, little aberrations is there, but it is all under control. Then you'll have some cancers which can be treated. But tamasic means all negative things. Tamas means negative, tamas means darkness. So if you have got a tamasic life, take all the carcinogens, you take non-vegetarian diet, so many other things are there. You take pollutions, the air is polluted, the water is polluted. So if we are all living in a tamasic lifestyle, probably we'll land up in the last third, that is incurable. So it's my very oversimplifications. I think Vishwajit will also agree with me. The oversimplification was not like that. So when the cancer treatment fails, the surgery, radiotherapy, recurrence, and metastasis occurs. So we go for second repeat surgery, second sessions of the radiotherapy, then chemotherapy. We go for this second line of initial. There is drug resistance. Then what happens? The drugs. Then we become targeted therapy because of the change in the cancer cells. We have target to the genes. So because the genes, they modify and they send the ligands to the cancer cells, and they try to bug up the cancer, the chemotherapy. So there also we target the specific genes in the tumor, and that's also called driver mutation, because the cancer cells are become intelligent. Whenever any chemotherapy is given, they try to mutate, they try to change. So this is also called co-pilot gene, that the gene becomes modified and sends another pilot gene to the cancer cells, so they become immune. So this target, that the new driver is there, and the cancer cells are attacked by this new targeted chemotherapy, and so that the cancer cells also try to evade. They are also very intelligent. I believe in Orissa there is a talk. If you go by branches, they will go by leaves. So, and here what happens? The T regulatory cells, and those who control the lymphatics which attack the cancer cells, they become modified, they become camouflaged, and the cancer cells avoid detection by the regulatory cells. So the second line of therapy started when there is such type of resistance. We start the second line of therapy. This is called intrinsic resistance. First, the drugs, the chemotherapy acts, and the cancer cells, the first 4 or 5 months, 4 or 5 cycles, 10 cycles, the cancer cells really respond, and that tumor becomes very small. But when there's intrinsic resistance, because of this, the changes in the gene, the drugs are not able to attack the cancer cells, and they avoid. And so if you change the drugs, the molecules, then it becomes really effective. Depending upon the cancer cells and available drugs, we can have the second line of treatments. Even sometimes the second line treatment also fails, and we have got a third line or additional rounds of treatment. So as the cancer progresses, we also, the doctors also try to change the drugs. So, and we attack the specific genes in the tumors, and it's also called driver mutations. We try to change the mutation so that the newer chemicals, newer drugs can go and attack the cancer cells, and there's complete mutations. So there's a need to switch over, add medication that targets the new driver, new change in the gene. But this immunotherapy also is another mode of attack to the cancer cells. We there also it can happen in several ways, and there are a lot of work going on in the cancer biology, and every day some
हम
new
भी देख रहे हैं कैसे लगता है इतना
and they are studying the best ways to try to overcome prevent the resistance of drugs, a big thing, and hopefully all this work by the immunohistochemistry, biology, and gene modifications probably will be hopeful to conquer cancer in the coming years. Now coming to the how to help the people who have got advanced cancer, the cancer is not curable. I'll share some of my patients' photographs, and let me declare here that in medical science, we don't disclose the face of the patients. We try to block the eyes, the identification. But in palliative care, we deal with the face, with the smile of the face. And if you block the eyes, there's no identification, and we don't communicate, don't convey the emotion given by the patient. So all my photographs will have the full face without any camouflage. And this is because I have taken specific permission from my patients that I will use their photos for treatment of the other patients and as well as education. So this here I am showing one patient. You can see the patient is lying on the floor with his abdomen touching the floor of our clinic. And why? Because that floor is cold, and he has been lying doing this for the last 7-8 days at his home in Bhadrak district. Why? And when his son tells the doctor, please, the doctor has come, please get up. Then he says, no, I am comfortable. Let the doctor examine here. So then he says, no, you have to sit up. Then he doesn't agree. Then I join him. I tell him, please get up. Then let me talk. Let me see your abdomen. What is the problem? Then he says, he falls at my feet. You can see he's trying to touch my feet and says, no, I'm okay here. And I don't know, unless I see, how can I? So we force him to sit up. And you can see, and the doctor there, local doctor has told nothing can be done to him. So that's why he is hopeless. So we force him to sit up, and you can see the face. You can see a picture is more than 1,000 words, and you can make up how suffering he is, how painful is the face, and there's no smile, and he's just severe pain, and he's closing his eyes. And then what to do? Our nurse gives her 110 milligram of morphine tablets, and this photograph is just about half an hour after the tablet, just in our clinic. And you can see this face and this face. Only 30 minutes gap. And this could have been done at Bhadrak, but he was not given anything. He was told, there's nothing more I can do. So what I say, that we must do something. And this photograph is another photograph. He has come after 15 days to take oral morphine tablets. And you can see the smiling face, and he's interacting with our colleagues in our clinic. So we should not, when the cancer progresses, we should not say that there's nothing more. Okay. There's always something little we can do. Even just touching the hand, that also is comfortable. And the patient feels that somebody is there with me. So in palliative care, what we do, we assess the symptoms, we do the management of the symptoms, we do the distress management, we provide services like other services like pain relief, physiotherapy, occupational therapy, nursing service, all these services are provided. And it's not a 1 month, so a lot of people, chaplain, social worker, counselor, they're all involved. So it's a teamwork, and it's a multidisciplinary approach that gives complete care to the patient. The WHO concept is an approach that improves the quality of life of patients and their families facing the problems associated with their life-threatening illness. So the prevention and relief of sufferings by means of early identification and impeccable assessment. We do proper assessment and treatment of the pain and other problems. Not pain is one of the major problems, but not the only problem. There are many other issues like wound, like swelling, nausea, vomiting, respiratory symptoms. So all these things, all these physical, psychosocial issues are addressed, and we also give spiritual support. So sometimes they have got a lot of big questions. Why I'm suffering? I've not done anything wrong. All this overall total package is given to the patient and they become comfortable. So this is the concept of palliative care. Palliative care is the word, Latin word palliare, that means to cloak, that's a cover, overcoat. It's an area of healthcare that focuses in relieving and preventing the sufferings of the patient. It is appropriate for patients in all stages of the disease, including those undergoing treatment. You can always start early stage, first stage of the disease from curable illness and those living with the chronic disease as well as. And there is a concept that palliative care is only for cancer. No, palliative care can also be for other chronic diseases like liver diseases, chronic heart diseases, lung diseases, all these things. Although it's not a cancer, they are also suffering very badly and palliative care can be given. What is palliative care? It's an active total care of the patient whose disease is not responsive to curative treatment. Control the pain, other symptoms, psychological, social, and spiritual problems is paramount. The goal of palliative care is to achieve best quality of life in spite of their disease. Many aspects of the palliative care is also applicable earlier part of illness in the anti-cancer treatment. It affirms life. That means life is given by God. Regards dying as a normal process, normal physiological. We should not be afraid of death. Death is normal and is a normal physiological process. Just like any machine, any car becomes 15 years, the government says it has to be thrown out. Similarly, God has given us, sent us to this earth and we live for some time. Then once our organs dysfunction, then it's the time to die. And so we should not be afraid of the death. We should neither hastening death or delay. Hastening death is euthanasia. That is not acceptable. And we should not unnecessarily delay death. Sometimes we put advanced cancer patients, we put them in the ICU, put them on ventilators. So that is also delaying the death. We should not do that. And we provide relief from the pain and other symptoms, as I told, integrates psychological and spiritual aspects of care. Because that is also very much important. If our mind is okay, then probably the relief of pain is also much better. The drugs act much better. And it offers a support system to help the patients live as actively as possible till the death. I got one patient who has got very advanced cancer stomach. He was having a very big tumor and he was a rickshaw puller and he was having so severe pain, he could not pull the rickshaw. So, and they are living on that meager income of the rickshaw wala. So we, as an anesthesiologist, I put a nerve block, celiac plexus block I did, and he had complete pain was relieved 90%. And he was sitting in the home and he told, sir, I have no pain. Can I go back to my work? So actually he has pulled his rickshaw till almost 2 weeks before the death. These 6, 8 months, 9 months, he was living in spite of the advanced cancer. He was viable, he was earning. So that is what we support them till the last breath so that they become, that they are not unwanted. They are also part of the family. They also contribute to the income. So that is what we should target, that they must be as actively as possible till the last breath. And lastly, it offers support system to the family as well. The family also is distressed. So we have to talk to the family, sit down, what is their problem, what is their other issues, like financial issues, like somebody has to marry off a daughter, somebody has a housing loan to be paid off, somebody has got some other settlement. Those things we talk with the family and give them support system so that the person before leaving this world lives peacefully without any disgrace, without any distress, that is something is unfinished, my daughter is unmarried, something like that. So we try to help the total physical health, psychological health, spiritual health, financial health. So overall, patient leaves this world in peaceful manner. So these are the 4 aspects of the pain. That there is physical, this is the most important. Pain is there, the ulcer is there, patient is not able to open the mouth, there is a swelling, he is not able to breathe, there is a dyspnea, there is tachycardia, there is ulceration, there is swelling in the legs. So all these are physical problems. But beyond that, there is social issues. Like imagine a patient having a breast cancer. Breast cancer has been removed by the cancer surgeon, but there's a deformity that whenever he goes out, they are people looking at her breast because one side breast is there, other side breast is there. That is a social pain she is suffering. She doesn't go out. Somebody has a big ulcer in the cheek because of the cancer, and there is fungus, there is a hole in the mouth. He's not able to eat, so he can't go out. There is swelling. So that is a social pain. Similarly, spiritual pain. why this has happened to me? I have not done anything. So he all those things. Why I'm suffering? Why I'm suffering? So he needs some spiritual support and emotional also. Again, what will happen to my wife? What will happen to my children? My income, my unpaid loan? All these things are addressed, and the patient is sitting here. So he's sharing all these. You can see physical, social, spiritual, as well as emotional. So once we know that patients is diagnosed with cancer, this is the presentation of the disease, this is the death. The patient lives for this total period, and this is the treatment given to modify the disease. But once we know that the disease is advancing, so and this is our presentation, what we do, we start this palliative therapies to relieve the sufferings or improve quality. This treatment, the red one is to cure it, this yellow is to support, improve the quality of life till the death. And as the disease progresses, you can see the red is coming down gradually, and at the death red treatment, that's the treatment to modify, is very minimal. But at the death, you can see the yellow is very high. So say 95% is symptoms control, and only say 2% is modifying disease. So at that time, the death occurs. But before that, we know that the person is going to die say few months. So that is called life closure. This deep yellow is life closure. We advise the patients to wind off his activities like paid off the loan or marry off the daughter or bring a house or whatever unfinished task he has got. So that we advise, that is called life closure. That means whenever he dies, his family no longer has to burden of his unfinished task. So that is life closure. But again, after some time, we know that patient is going to live very few hours or a few days. So that is called last hour of life or the dying process. So this deep orange is the last hours. We give them support. We withdraw all ventilator, all expensive treatments we withdraw, and patient is allowed to live. And if possible, we allow the patient to go home, spend the last few hours with the family, with his relatives, with his grandchildren. Everybody is there, so that the last days, the death is happening in the amidst all near and dear ones. Then the death occurs. This is the death. But after that, our duty is not over. There's a bereavement. The wife has to be attended. The children has to be. There's a big vacuum. There, the palliative care physician also visits the house and supports. This is called bereavement care. After the death of the patient, we support. So this total from here to here is total palliative care. So you can see it's very broad, starting from the diagnosis, including death and bereavement. This is total palliative care. It's a big, long process. So palliative care involves control of the pain, which is very, very important, control of other symptoms like respiratory stress, tachycardia, ulcers, fungations, then psychosocial and spiritual issues are also there. And I'll share some of my patients. This is a lady teacher. She was suffering from advanced malignancy of the cancer cervix. She was operated, but unfortunately, because of they did remove the nodes, so they had some problem, and she developed edema of the legs. She was not able to go to the school, and she was always bedridden. Everything she was doing from her bed, and you can see both the legs are just like elephant legs, and she's not able to do any other activities. And she was a very good teacher. She means her students had to come home. But we gave some massage therapy, compression therapy, and you can see after 3 weeks, she is able to stand. Of course, this right leg is not as good as the left one, but she is able to stand. With this, she went to the school and she was taking the classes, and she lived for almost 3 years after this. And these 3 years, she was very active. She was in the school. She was very happy and she was content. Students are content. So with this, she was unable to move out of the bed. And here she can see in her classroom, she's teaching. So this is what, even if there's almost 2 to 3 years she lived, although she died of the cancer, but continuous lymphatic drainage treatment was given. So she was very active and she died a peaceful lady, a Muslim lady. Similarly, the management of oxygen, sometimes we have to give oxygen, but we have to see that if you give oxygen and there's no benefit, we have to explain the patient and stop, because if the lungs are really damaged, not any extra amount of oxygen will not be of any use because the lung parenchyma, the area where the lung is taken up by the body is damaged. So no point wasting the oxygen. Rather, it is better to give it to another patient like a road traffic accident victim, a young boy who is having flail chest. Oxygen is much more beneficial for him than this advanced cancer, lung cancer patient. So again, there is justice. We have to see judicious use of the resources. Resources should not be wasted. Here also, and cancer doesn't affect only the elderly. A small kid having a retinoblastoma, and you can see severe pain, and there is ptosis of the eye. But you can see she is playing with the hospital staff, and she is having severe pain was there, but now she is smiling. So with proper treatment, we can bring smile even at the last stage of the disease. Here another person, railway driver, has a big cancer cheek, he was a tobacco chewer, and having severe pain, and we gave a nerve block. You can see within 10 minutes, see the smile. This is the distress and this is the smile. So symptom control, we have to do. Pain is the tip of the iceberg. When the patient complains of pain, the pain is only part of the symptoms. And once we remove the tip, like iceberg, ice actually 90% ice is inside and only 10% is above. So once we remove the tip, that means the pain is removed, the ice, once you remove the ice will come back another 10%. So if you remove the tip, ice disappears. Then we, just like the ice, if you remove the tip, the pain comes back. Here, the pain is, the patient comes for the pain, and many other symptoms are already below the water level. That is not visible. Once we remove the pain, you can see the ice has come up, and the respiratory symptom, the dyspnea, the chest pain that has come up. So we try to remove that. Once we remove that, the gastrointestinal, the nausea, vomiting, that was hidden by the respiratory system, that will come. So gradually, one by one, remove till all the symptoms are removed and the entire ice is removed. So after one by one, usually the patient comes with pain, you remove the pain, then this respiratory symptom, gradually one by one remove till the patient is completely pain-free, other symptom-free, and patient lives comfortably till the end. And for palliative care, we need 3 H. H is for heart, another H is for head, and the third is for hand. So, heart is attitude. We should have a soft attitude. Yes, I must try to help. Whatever little I have to do, I must have that attitude. Then second is head. That means knowledge. Unless I know, I have to apply my head, my intelligence, my knowledge, my medical knowledge. So knowledge is required for palliative care. And last is the heels. I must know the skills, how to give a nerve block, how to put a right strip, how to do a lymphedema massage. If I apply the 3H, heart, head, and hands, with attitude, knowledge, and skill, definitely I'll give very good quality of life. And for that, I must listen very actively. Listening. Normally, our doctors in the clinics, they have no time. They just talk and talk. They never listen. So here you can see we have got visitors from America. These two are the doctors from MD Anderson, Houston. So they had come and they had seen our patients in our clinic. And you can see how keenly they are listening. These two. These are Dr. Bruera, the head, and this is Dr. Reddy from MD Anderson. Intent listening is important. Similarly, here also, one-to-one listening is there. The boy is in severe pain. The mother is there. Mother is happy that patient doesn't have any pain. The boy is interacting. Similarly, roadside also I had got some patient and this lady was in severe pain. Could give some tablets and she was really. Similarly, another visitor also very much one-to-one listening is there and eye-to-eye contact is there. That is very, very important for palliative care. Proper. So the patient must assured, but feel that this doctor has got some time. So you can see the doctors are always sitting and talking to the patient, and eye-to-eye contact is there, and they have got all the liberty to speak anything they like. Similarly, here also active listening. Active listening. This the lady who saw that now in the smiles, we are in the oral morphine, and we are given some Vedic chanting also, and she is chanting, and because she is in severe pain, it's a very advanced cancer of cervix. I show you this patient, how comfortable he is. Here also the patient is in distress. So we have to make the patient as comfortable as possible till the last breath. Although the world is full of suffering, it is also full of the overcoming. I think that's my last slide. And if there's any questions, I can take.
Thank you, Sukdev, for your wonderful presentation. So now the floor is open for anybody to ask any queries if anybody has. So maybe I will start with one
Yes.
question.
Yes.
So what I have seen that a number of patients, for especially those suffering from cancer, especially when they are told that they don't have any proven medical avenue available for treatment, so they would normally shift towards Ayurveda and all kind of say unconventional treatment paths. So does palliative care also sensitize them that they don't have
Yes.
carry as much benefits as proven?
We encourage alternative medicine because there have been a lot of research into this alternative medicine, yoga, pranayama. I always recommend my patients to, because once you chant, they say by chanting your immunity increases, your the tolerance increases. And I have already one study is there in AIMS Bhubaneswar where we introduced Om chanting with oral morphine therapy, and it had proved that the dose of oral morphine is coming down once the patient, those who are listening to Om chanting, those who are listening to music of their own choice, there's minimal change. But with Om chanting, there are some primordial changes in the our limbic systems, and really the morphine consumption was reduced. So we encourage yoga, pranayama, and other therapies. We don't stand on the way. We don't refuse them.
Any other question from any other participant?
Yeah, Sukdev.
Yes.
I just wanted to ask: is palliative care medicine is there in all hospitals, or it is being practiced only by a few anesthesiologists? What is the scenario in India?
Actually, palliative care started in India in 1986. D'Souza surgeon, he started a palliative care clinic, Santi Avedana Ashram in Mumbai. After that, the 86 and 1994, the IAPC, Indian Association of Palliative Care, was born, and it was mostly the anesthesiologist who was doing blogs and other things. They started, but now it is a big, fully grown, lot of medical oncology, surgical oncology, radiation oncology, the immunotherapy, they have come. Now it's all expanding, and Government of India was one of the first to propose palliative care services in the WHO. But unfortunately, for almost 10, 20 years, they didn't implement it. Right now, they have made it to all hospitals compulsory, and NABH also accreditation is palliative care is a must. But these are all mostly in the papers. However, last 3-4 years, there are a lot of activities in teaching, because there are no teachers. Those, about 50 doctors are taught, taken to UK, WHO Indo-British program to train, and luckily I was one of the participants there. So there are about now there are about 100 centers doing palliative care in India, but out of these 100, maybe 80 are in Kerala, and other states 1, 2, 3 centers are there. But government has made it mandatory to be included into the chapters of MBBS curriculum as well as MD curriculum. But again, it will take long time because there are no teachers in palliative care. That's why they want to bring up MD palliative medicine courses. Now there are about 7 teaching programs in 7 different colleges, MD, and DNB around maybe 8, 9 colleges. They have started DNB too. So right now I can say around 20 to 30 seats of post-graduation in palliative medicine are running. I myself tried to start palliative medicine in my first center, that is Acharya Hari Regional Cancer. I could not, I stayed there. But again, at AIMS also I tried, but I couldn't succeed. Hopefully, after my retirement, I am with the 2 private medical colleges. I have convinced them. Hopefully, Odisha will have one center where there will be palliative medical education. Right? Government is trying its best, but government will write some, they will not follow up. So definitely there is a positive palliative care services, and there is one WHO study where they say only 4% of the patients who need palliative care are getting. So 96% of the patients of those are suffering from cancer, they do not have any palliative care services provided in India. So there's a big, very bad picture.
That is what. Okay.
Only 4% are getting this.
Very sad.
Very bad. Hopefully another 4-5 years it will be good.
Chalo. Any other question?
Anybody else would like to have any comment or question? I don't see anybody raising their hand, so I think we can now conclude the session.
Yes.
So first of all, thank you, Sukdev, for actually taking
welcome.
the time from your schedule and giving this wonderful presentation for all of us. And thank you to all the participants who actually waited very patiently, because we had quite a delay for starting the session, but you all have waited, and I am sure you all have benefited from the session. So thank you all for that. And with that, I would like to close the session, and maybe we can stop the recording, and if anybody would like to stay for a informal chat, we can continue.
Satyam,
yes, sir.
You can put the slides in the website, so anybody wants can share for education purpose, something like that.
It will be shared. It will be shared.
Yeah. Okay.